At Nashville Knee and Shoulder, we treat a variety of issues related to sports medicine with a specific focus on injuries of the shoulder, knee, ankle, and wrist. Today we'll be doing an in-depth overview of a real-life case we treated here at the practice. Before we dive into the details of this ACL reconstruction, let's cover a few common issues that patients dealing with an injury might experience. The number one issue that we see with patients that are in need of an ACL reconstruction is a sudden and significant injury involving a pop, twist, or the sensation that your knee gives out on you. Patients will also likely feel pain and instability when they try to put weight on the injured extremity. Lastly, the inability to pivot, turn, or cut without pain is a strong indication that they might require medical attention. In this particular scan, this is a patient that recently had an athletic injury and ended up with an ACL injury. The patient has other problems in this MRI as well, which we'll go through as I examine this MRI. The first view we'll look at is the coronal image. The coronal image is the view as if we were looking directly at a patient. As we scroll through this MRI, which we scroll through in 2 millimeter increments from the front to the back, you begin to see the ACL in the middle portion of the knee. The ACL resides between the medial and lateral condyles. It starts on the medial aspect of the tibia and travels to the lateral femoral condyle on the inside of the knee. You should see a very dense, dark ligament in this position. In this particular MRI, the patient has suffered an ACL injury, so what you see is a break between the top and the bottom of the ACL. Some of these fibers are torn and folded inwards. When you look at the back of the image, you see the PCL. This is what a normal ligament should look like, and it's a good comparison to make when looking at an ACL injury. Also on this coronal image, on the lateral aspect, or the portion of the knee that's more to the outside of the patient, you start to see these bright white areas. This is compatible with what we call edema in the medical world. Edema is basically an increased signal that correlates with bruising, or increased blood products in an area. At this point, we're going to change to the sagittal view. The sagittal view is the view that we look at if we're looking from the patient towards the side. As we scroll through this image, once again in 2 millimeter increments, the first thing that we notice is that the lateral femoral condyle, or the outside of the bone, once again has this bright area of signal that correlates with edema. This occurs in almost every ACL injury because when the ACL tears, you lose the anterior to posterior stability. The medical term anterior and posterior refers to anterior to the front, posterior to the back. So the knee shifts violently from the front to the back when you have an ACL injury. The bones hit together pretty violently and result in this increased edema or bruising on the bone. As we continue to scroll through this, in the front portion, you see this bow tie shaped structure. This is the meniscus. The meniscus is the padding in the knee, or I also often call it the brake pad of the knee. As we get older, the meniscus sometimes degenerates and you lose that padding. That leads to a host of other problems, including arthritis. But in this particular patient, we're looking at the meniscus because when there is that shift of the ACL injury, sometimes the meniscus tears in response. Lastly, in the center of the knee, you see where the ACL should reside. Once again, we notice the PCL on the back. This is always a good comparison to what the density of a ligament should look like, but in this particular case, the ACL has this bright white signal, and that is compatible with a recent rupture. In the initial part of this video, what we've done is we've positioned the knee. This means that we put the knee in the best possible spot for us to do the surgery on. In general, what we do is we place this in what's called a leg holder that holds the upper portion of the leg still, and then we're able to manipulate the lower portion of the knee. This allows me to stress the inside and the outside of the knee and allows me to gain access to parts of the knee that I otherwise would have difficulty obtaining access to. Now in this part of the video, we've established what we call medial and lateral portals. What that is the initial small incisions that we're able to insert instrumentation through. The first instrument we'll place is a camera. This allows me to view and look for the different injuries throughout the knee. The other instruments that we typically use are what's called a probe. That allows me to grasp structures and check for tears and also loose pieces of tissue or cartilage. Lastly, we'll use a small metal device called a shaver. What this is a rotating blade. We can use this to remove portions of damaged tissue or small pieces of tissue that aren't where they're supposed to be. Once we have obtained access to the inside of the knee, we'll check the menisci. These are the two brake pad type of structures in the knee. This provides stability and support for the knee. In most ACL injuries, there's some type of injury to the meniscus. In most athletic individuals, the meniscus is also fixable. Not all the time, but especially in young athletes, I do everything I can to fix the meniscus. Once we've identified a meniscus tear, I need to identify what type of meniscus tear it is. This can come in several different forms, and this really just correlates to the type of tear and the pattern of tearing that the patient has. The most common type of tear that we see is a lateral meniscus tear. The most common tear type that we see is a vertical tear. This is when the back portion of the meniscus tears. The reason this happens is because the lower portion of the knee, the tibia, jumps out in front. The meniscus is subsequently caught by the upper portion of the bone and then tears. Occasionally, patients suffer from what's called a bucket handle tear. This is named because the tear extends not only to the back, but around to the front of the meniscus. The remaining structure of the meniscus then flips into the joint and resembles the handle of a bucket. This is fixed in the way that we reduce the meniscus back into place, and then there's surgical sutures we can use to stabilize the meniscus within the joint. The next part of the case that we'll look at is what's called the intercondylar notch of the knee. This is where the ligaments that reside inside the knee rest. There's the PCL, which we can see here on the left side of the screen. The ACL used to live here. What we see now is a massive scar tissue. This is the body's poor attempt to try to reconstitute and heal the anterior cruciate ligament. The anterior cruciate ligament is extremely vascularized, so the body can, in some instances, heal this, but once the fibers have completely torn away, the possibility of this actually happening within a patient's knee is extremely low. There are techniques to try to get the ACL to heal itself, but this has to be a particular type of tear for this to be successful. In this particular patient, the ACL is completely torn. We will need to place a new ligament to function as the patient's ACL. In this particular case, we've decided to proceed to a bone-tendon-bone type of reconstruction. What that means is that we'll take the center portion of the kneecap itself, and then we'll take the tendon which attaches to the inferior portion, and then also a small piece of the bony attachment called the tibial tubercle. We'll use this as a new ACL. The two bony portions of this tendon are used as anchor points. One will be anchored in the top bone or the femur, the other will be anchored in the tibia below. At this point, we've removed the ACL. We're also opening up space for the new ACL to reside. We've created an opening on the anterior aspect of the lateral femoral condyle and allow us to have better visualization to the joint itself. We'll then measure a position roughly 7 millimeters off the back of the lateral femoral condyle itself. A pin can be shot up into this point to act as a marker. From this point, we'll use what's called a medial portal approach. We'll place a flexible pin through this initially marked position and adjust this up and out the lateral cortex of the femur. This will be the origination of the bone tunnel that we'll use to anchor the upper portion of the new ACL ligament into place. At this portion, we're reaming a bone tunnel. What this means is we're removing bone in a 10 millimeter diameter to allow the new ACL to sit within the upper portion of the knee. This will be held into place by a metal screw at the end of the case. At this time, we've used what's called a tibial guide, and we're drilling a pin up into the portion of the knee that will be the starting and origination point for the lower portion of the new ACL. This is inserted into the intercondylar notch. At this point, we ream over this pin to create a 10 millimeter bone tunnel. In this way, we can pass up the new ACL ligament. This will be passed from the tibia and then will be lodged into the femur on the top portion. The diameters of both the tibial tunnel and the femoral tunnel need to be big enough to accommodate the new ligament itself. And in this particular case, since we're using a bone tendon bone type of reconstruction, we have to base these new bone tunnels. The size is based off the size of the bone block from the new ligament. At this point in the case, we've established bone tunnels for both the femur and the tibia, and we're pulling the new bone tendon bone construct into place. This will be the patient's new ACL. Once this is lodged into the femoral bone tunnel, which we've already created, we will lock this into place with the use of metal screws. One metal screw is placed anterior in order to push the bone plug slightly posteriorly. This allows for a more normal position of the ACL. We then tension the ACL and we'll cycle this in order to create maximum tightness around the ACL. Once this is fully tight within the new tunnel, we'll extend the patient's knee. A small posterior drawer, which essentially means a small posterior force is applied to the lower bone. The patient's knee is flexed slightly to 10 to 15 degrees. Lastly, the bone plug on the bottom bone tunnel, which we created, is locked into place using an additional metal screw. In some of these cases, the patient's tendon is slightly longer than the new path that we've created for the ACL. In this case, we can occasionally use different types of screws to allow pressure across the actual tendon itself. When the pressure is being placed across the bone plug itself, I prefer to use metal screws to allow maximum compression across the new bone block. At this point, we've completely reconstructed the ACL. You could see the new ACL ligament in the center portion of the knee. We will test this by flexing the patient's knee to 30 degrees and providing an anterior force on the lower bone, which is the tibia. We want to see the ACL catch and hold the lower bone firmly in place. We also want to see the knee in extension to have the ACL at full tightness. As we flex the knee, the ACL becomes slightly more lax, and this correlates with the normal anatomy of the patient's anterior cruciate ligament. Now, let me introduce you to Rob from our care team. He's going to review how the days and the weeks after an operation will be handled after an ACL reconstruction.
Welcome to your comprehensive guide on post-operative care and rehabilitation following ACL reconstruction. Immediately after your surgery, your brace will be locked in a straight position. Wear it this way whenever you're upright while sleeping. You can gradually weight bear on your leg as comfortable, often discontinuing crutches within the first week. However, if we repaired your meniscus along with your ACL, we will delay weight bearing for an additional 2 weeks. You will have your first post-op appointment 7 to 10 days after your surgery. At that appointment, we will review the operative pictures with you that we took during the surgery, as well as answer any questions you may have about your ACL reconstruction. Physical therapy should begin within 2 days of surgery. Sessions planned 2 to 3 times a week. Your therapist will guide you through tailored exercises and monitor your progress. Let's break down your rehabilitation into phases. Phase 1 is weeks 0 to 2. Your main focus will be on decreasing pain and swelling, maintaining full passive knee extension, and achieving about 90 degrees of active flexion. Next, with phase 2, it'll be a little bit more intensive. This is weeks 2 to 6. You'll start to bear full weight while wearing your brace locked in extension. Your goal is to restore range of motion and muscle function. Focus on improving endurance and control with exercises such as leg presses and hamstring curls. We will discontinue use of the brace depending on your quad strength. Most patients are able to discontinue use of the brace after about 4 weeks. Moving on to the final phase, which is the advanced phase, weeks 12 to 22, your rehabilitation progress will start to include sport-specific drills and higher intensity workouts like sprinting, jumping, and cutting drills. You will also engage in functional testing to ensure you're ready for your activities. It can take 9 to 12 months to return back to full contact sports. Throughout your recovery, remember to manage pain with prescribed medication, elevate and ice your knee, and follow wound care instructions provided. Always consult your healthcare providers with questions or concerns. Remember, every patient's recovery is unique, so follow your specific instructions and stay in close contact with your care team. Thanks for tuning in. If you have any questions, please reach out to me, Josh, or Ansley, and we'll look forward to seeing you at your first follow-up appointment.
If you or any loved one are dealing with an ailing joint, reduced mobility, or chronic pain that just won't go away, reach out to our team and schedule an in-person consultation. We'd be honored to play a small part in getting you back on the field of play, whatever that field might look like.